Meet Dr. John. He's a family physician who got into family medicine because he loves building connections with his patients. He has served the families in Springville for over 40 years now. The families of Springville love him very much. He goes out of his way to make sure his patients are well cared for. However, Dr. John's patients are beginning to age. For those who are very sick, he tries to manage them for as long as he can in his very busy clinic. But often, he loses connection with his patients when they receive most of their care from specialists, such as oncologists. But when they are close to death, the oncologist refers his patients to Dr. Mary, without first speaking to Dr. John about the referral. Dr. John does admit that he's usually relieved that the patient is referred to Dr. Mary because he hasn't seen many patients for years, and now the patients need end-of-life care. Dr. Mary is glad to take over the care of Dr. John's patients. She is also a family physician, but has completed extra training to specialize in palliative care. She loves caring for people at the end of life because she knows how vulnerable patients and families are during this time, and she loves to act as a good support system for them. And she especially loves working in patients' homes because that's where most people want to receive care. She makes home visits, provides them with 24/7 access to her pager, and has expertise in managing complex symptoms. She mostly gets cancer patients, usually very close to death, and often with a lot of complex issues. But she is starting to burn out. She realizes that while she has this special level of expertise, some of these cases could be handled by Dr. John. In fact, sometimes her patients even express that while they are grateful for her care, they feel abandoned by their family doctor, Dr. John, who has known them for an extensive period of time. She also realizes that there are so many other patients that are afflicted by something other than cancer that could also benefit from a palliative care approach. It's also difficult for Dr. Mary to take time away from her practice because there is no one else who provides palliative care in Springville. Recently, Dr. John and Dr. Mary attended a talk about a palliative care approach given by a research team at McMaster University. The team suggested that palliative care is everyone's business, and that all primary care providers need to know the ABCs of palliative care. This way, they would be able to better identify patients who could benefit from a palliative care approach earlier on in the disease trajectory, and thus improving their quality of life. The research team also said that there will never be enough specialists to provide palliative care in order to meet the growing needs of patients, and while specialists are needed to manage the most complex cases, specialists also have an important role in building the capacity of primary care providers. Dr. John gave some more thought to this new approach. He wants to provide the best care for his patients, but he's worried about a few things. So he decides to express his concerns to the research team after the talk.
I'm afraid that my workload will increase exponentially. To me, good palliative care requires a lot of time, and my clinic is already very busy. I'm worried about opening Pandora's box, meaning that if I identify patients earlier, I think I will become overwhelmed by the large number of patients that require a palliative care approach.
The research team explains to Dr. John that by identifying patients earlier, it will help to proactively plan for what's coming ahead and prevent serious problems from arising in the first place. This makes the work more manageable. Knowing how to have the right conversations and navigating the patient through the system is a skill that can be taught and practiced. It doesn't always take more time, but it does require one to explore different issues and needs during the visit. The team also reminds him that many patients want to remain in the care of their family physician, whom they place a lot of trust in. They remind him that the family also needs care and that he will need to face the survivors after the patient's death. Even though the patient has been referred to Dr. Mary, the family is also part of the unit of care, and they weren't referred to Dr. Mary. It's true, Dr. John sometimes wishes he could remain as the responsible physician for his patients and not feel so out of the loop. Dr. John expresses further concerns, saying,
I am not confident in the knowledge that I have about palliative care. Plus, how will I provide 24/7 care without any support? And what about the time needed to coordinate care and perform home visits?
The research team explains to Dr. John that they have a study underway which will provide him with evidence-based training to increase his knowledge, and that this approach requires a local team of primary care providers with mentorship from specialist providers. So he won't be alone. The home care nurses can be his eyes and ears in the home, the other primary care providers on the team will share the on-call duties, and the specialist mentor is there whenever advice is needed, kind of like a phone-a-friend. The study will also provide education around billing for home visits and other palliative care services. Dr. Mary was also thinking about this new approach. She too wishes that her patients receive the best care possible and realizes that there are many more patients that could benefit from palliative care than she can care for. But she also has a few concerns, which she expresses to the research team.
If I provide mentorship to primary care providers like Dr. John, I'll have to put in more work and I won't be able to bill for it. I will be preventing my own supply of patients and I will lose significant billings if I use this approach.
The research team responds to Dr. Mary by first explaining that there are several ways to bill for providing advice to and consulting with primary care providers. Also, by building the capacity of primary care providers to do the ABCs of palliative care and identify patients earlier, when a specialist is needed, it won't be when the patients are days away from death, or basically when the wheels have completely fallen off the cart. They think that this constant crises management is part of the reason she often feels burnt out. The team also explains that there's so much need and so few specialists for palliative care, and that there will always be lots of patients who need more than just the ABCs of palliative care. And those patients need the expertise of specialists like Dr. Mary. The research team further explains to Dr. Mary that she will continue to have a robust practice and become the most responsible physician to a number of complex end-of-life patients. But for the majority of patients, she will be helping support the primary care providers to build their skills in order to manage uncomplicated cases. And she will benefit by billing for that advice, getting involved before the cases become too complex, and supporting a sustainable health system for the community she loves so much. Dr. Mary then thinks to herself,
But family physicians won't be able to provide the same level of expertise as me. I mean, they don't make home visits nor do they provide 24/7 care. It seems like they just want to hand over their patients to me. Plus, even if they did want to be mentored, I have no training in how to be an effective mentor.
The research team then explains to Dr. Mary that not every patient needs specialist care all the time. Many need the ABCs of palliative care and early on, like talking about advanced care planning and preparing for expected physical decline. Furthermore, there are many family physicians that want to provide palliative care. Many feel that providing cradle-to-the-grave healthcare is part of their primary care identity, and in fact, one of the most fulfilling parts of their jobs. It's true that not all family doctors make home visits. However, the visiting nurses are important team members and can often make most of the home visits on behalf of the primary care practice. Moreover, for family doctors to be able to provide 24/7 care, they need to know that they can rely on a specialist team for support. Anecdotal research has suggested that knowing that a specialist is on call for support is often enough, and calls are minimal. Many primary care providers know that they need to build their palliative care skills, and they wish they had a specialist mentor to call when difficult symptoms arise, or to refer to when the cases require more specialized care. Lastly, as for how to be an effective mentor, well, that's exactly what the research team's new study is all about. Both doctors realize that this current way is not sustainable and is only providing good care to just a select few individuals, and not everyone. They want to be part of a system that provides better access to early palliative care to everyone who needs it. But where do they start? They think back to the new study that the McMaster research team was talking about in their presentation called CAPACITi, which is about building interprofessional teams of primary care providers who are supported by specialist providers in the local community. The study will provide education, materials and tools, measurement support, and coaching. Most importantly, it will dedicate time and energy to help understand how to implement a palliative care approach in a way that makes sense in the local community with local providers. Dr. John and Dr. Mary team up to join the study, and they hope that you will join too.